This podcast is brought to you by the ATMS, the Australian Traditional Medicine Society. This is FX Medicine. I'm Andrew Whitfield Cook. Joining us on the line today from New Zealand is Lara Briden, who's a Sydney naturopath with more than 20 years' experience. She first trained as a naturopathic doctor in Canada and then moved back to Sydney in 2001. Lara is a passionate communicator about women's health and alternatives to hormonal birth control. Her book, The Period Repair Manual, published by Pan Macmillan and now in its second edition, is a manifesto of natural treatment for better hormones and better periods, and provides practical solutions using nutrition, supplements and natural hormones. The book has been an underground sensation and has worked quietly to change the lives of tens of thousands of women. And Lara will also be speaking at the ATMS Symposium in Sydney on the 16th of September 2018. We'll be speaking about the drivers of PCOS, and that's what we're here today to discuss. Welcome back to FX Medicine, Lara. How are you?
Hi, well, Andrew, thank you so much for having me.
Now, I was enamoured by the first time you joined us on FX Medicine, and indeed when I heard you speak at the 2017 ATMS Symposium. That was just an awesome educational experience. But today we're going to be talking about something that there's a lot of circulatory sort of things happening here with PCOS. So I think we first have to get a definition. What is PCOS and what isn't it?
That's a very good place to start because the condition is, I'll venture to say, rather loosely defined. You know, unlike some other women's health problems such as endometriosis, which is a very specific disease, PCOS is best defined as kind of a group of symptoms. And in that way, it's an umbrella diagnosis because I think women can come to that place for a lot of different reasons physiologically, but most fundamentally, the group of symptoms are irregular periods, so irregular ovulation. And then the second key symptom is excess male hormones. And so they're different, as I have discovered in my work and through the research there are different drivers or processes that can bring a woman to that place of having those two main symptoms. And
like my historical background of this, when it was, I think people started to first define it and they tried to over-define it. There was this apple-shaped obesity, there was the Hirsutism, there was a cardiovascular paradigm in there as well. But that's not always present as I now understand it. Is that correct or not?
That's correct, because it's really, I'll take it as kind of an assortment of a few different conditions, I think, that qualify for the diagnosis of PCOS, which is why I really think we need a new name for the condition that's in the works, potentially, to define it based on androgen excess. And I would propose we perhaps even need a few different names, depending on to what degree there are insulin resistance or some of the cardiovascular parts of the picture. That's, in my view, that's kind of a distinct condition.
And I also remember the PCOD, Polycystic Ovarian Disease. So there was this attempt to define it as a disease rather than a syndrome, as you say, a collection of symptoms. And the other part of it is there's also polycystic ovaries,
which is not a thing.
I'll
say for what it's worth, that ultrasound finding of polycystic ovaries on its own, without any other evidence of problem, is not a condition. It doesn't define anything. And it's actually really, I'm glad this came up near the beginning of our conversation because there has been a trend to overdiagnose PCOS based on that ultrasound finding. So you might have women who just came off the pill, for example, or have lost their periods because they're under eating, or there could be lots of different scenarios. And many of those women will show up with polycystic ovaries on ultrasound, but they don't have the androgens and the insulin resistance and some of the other things going on. So their doctor, says to them they have PCOS, and then they're looking essentially in all the wrong places for the solution of what they need to do. That's a lot of what I do in my clinic, is working through that confusion and trying to guide women to a more accurate assessment.
Okay, so what do you do to arrive at that? Do you look at levels of androgens? Do you look at perhaps some cardiovascular markers, or indeed doing a fasting insulin? Do you look at that sort of thing?
I do a fasting insulin, but I'll give you my little flow chart. So step one is the big question of do you qualify for PCOS diagnosis, which would mean, is there some evidence of anovulation or ovulatory dysfunction, and is there some evidence of excess male hormones? So that evidence for the male hormones could be male hormones on blood tests, not saliva tests. I'll say at this point, you cannot pick them up with saliva test, or if you do see elevated male hormones on saliva test, it's not accurate.
Right.
I will venture to say, or may not be accurate. But blood test is what I use. So I'll test testosterone, DHEA-S, androstenedione, some of the androgens, and also at the same time look for elevated prolactin and rule out some other conditions. You can use the blood test to rule out other conditions that can cause elevated androgens. So that's step one. The blood test for evidence, and the second evidence for androgens would be clear physical symptoms like facial hair, body hair, hair loss, a particular pattern of hair loss, perhaps acne, although acne is on its own not a defining symptom of androgen excess. And if that's all present, and then I can say, yes, you definitely do seem to be qualifying for a PCOS diagnosis, at least at this stage, then the next step in the flowchart is, and you said it just a couple of minutes ago, is do you have insulin resistance? That's the very next question to answer. One
of the other big surprises for me as well was, how I immediately pigeonholed women into this, particularly the body shape, the apple-shaped obesity, that sort of thing. And yet I've met quite a few women now who have PCOS and are the fittest, in some cases, slimmest, trimmest women, that I know. And yet they have this issue that they constantly, battle against. So
absolutely,
how do we break that picture? And, how do you, when somebody's presenting with you, what's the key thing that you go, hang on, there's something happening here?
Well, again, it's, if they qualify for that first step of the irregular ovulation and the high androgens, then we know there's something going on. So then the next step is to determine if they have insulin resistance. That usually means testing either fasting insulin or a glucose tolerance test with insulin. It's not enough to just test a blood glucose, or even, I would argue, even just a normal glucose tolerance test.
No.
And then determine if insulin resistance is present. So, and just as you said, it may be present. Even a lean woman, a not overweight woman, can have insulin resistance. So that's why that testing is so important. You can't just assume it's like, oh, you're skinny, therefore this is not what's happening. So that step is very important. But then there are, because of the nature of the way this condition is loosely diagnosed or defined, there are then going to be some women who are qualifying for PCOS but don't have that main underlying driver of insulin resistance. So then it becomes a bit more of a, put on the detective hat and try to identify what has, for that particular woman, what has kind of pushed her into the state of high androgens, recognizing that for anyone who moves into a state of high androgens, there's going to be some underlying genetic tendency to do so.
Gotcha.
It's sort of a mismatch with the environment. They, for whatever reason, a combination of genes that they have under certain pressures, whether it be insulin resistance or other pressures, coming off the pill might be an example, they then move into this hormonal state. And it's reversible. This is the other thing that's important to understand. I mean, we hear that there's no cure for PCOS. I would say that's true, in that women who have this tendency, probably a genetic tendency, are always going to battle against it to some degree. But the consensus amongst the experts that I've spoken to, and myself included in this camp, I think for many women, the symptoms are reversible. Therefore, by definition, once you don't have active symptoms, you really move out from under that diagnosis. Yeah. You might move in and out of it. Like you might have it and then it's like, oh no, you're clear. And then move back in. But the other thing that happens with PCOS is you can tend to outgrow it. So there was recently a paper, Australian paper, called, I'm trying to get the exact name, it came out in the British Medical Journal just a few months ago, saying they called it our expanding diagnostic criteria causing overdiagnosis amongst women for PCOS is basically the title. And they make a few points. One that I said earlier, that ultrasound on its own is not adequate for diagnosis. And they also make the point that many women, this is something is more of a problem when they're young. So most teenagers are in kind of a mild state of PCOS anyway. That's kind of normal for them. And then, as you move into your 20s, 30s, a lot of that for many women, will tend to improve on its own. So that's something important. In that paper, they're saying that's important to communicate that to women so that they don't get too scared. But it's quite frightening to be told that there's something wrong with your ovaries. But in reality, for many of them, it's possibly just, a stage that they're in.
And indeed, I guess once anybody, any woman in this case, gets a diagnosis, it can be either or both an answer, a relief to know what's going on, but also once you know that there's something, let's use the word wrong, that they can then go through even like a grieving period, a shock period to adjust to.
Yeah, absolutely. Well, I guess how I would describe it is they can kind of freak out, be very scared and start, taking a lot of treatments and including diet, that they might not need. And even just the anxiety around that can worsen the condition. So I'm trying to reframe the condition a little bit. I know it can be very serious for some women, but for many women who have been given that label of PCOS, it's relatively probably quite a mild situation and doesn't mean they're not going to be able to have babies or anything like that long term.
The interesting thing is when I was nursing, this didn't exist. It just never came up.
Yeah.
And then it was basically as soon as I finished nursing, and then this term started to be bandied around and became more and more and more common. So is it a case that we're picking it up and answering questions that we overlooked before, or is it really becoming more common?
It's both. It's being overdiagnosed, at least in Australia. I'm convinced of that. And that's explained in the medical journal, British Medical Journal paper that I mentioned. But at the same time, I think there is a growing trend to the problem. And I think one of the main reasons that's becoming more common in the last few decades is because of insulin resistance. So as we know, metabolic syndrome or insulin resistance is becoming more common. I think there are a few reasons for that, probably, but that's one of the downstream effects of that for women is PCOS.
Okay, so in the meantime, I just found that reference. It's Tessa Kopp. The reference is Are Expanding Disease Definitions Unnecessarily Labelling Women with Polycystic Ovarian Syndrome. It's BMJ 2017 for everybody. We'll put that up on the FX Medicine website for you to review. That's brilliant, Lara. I just wanted to go on. You mentioned genetics before, and I have to ask the question, is part of this that, obesity, calories conserving gene that we unfortunately have favoured through the Ice Age in human development, human evolution, and now, of course, we've got overabundance of calories, so it's now our downfall. Is that one of the issues? And what other triggers do you see with PCOS?
So with regard to metabolic syndrome type of PCOS, yes, that's pretty close to the situation. I think that some of us in the population, have ancestors who were well adapted to famine. You could see that as a superpower, really. They were able to keep making babies, keep reproducing, even in the face of low food supply, which was great for them. But now there's a mismatch with our modern world, not just in terms of excess food supply generally, but in terms of sugar specifically. I think when a diet high in fructose hits that genome, kind of combines with that thrifty metabolism, as they call it, the results can be insulin resistance. And that we know from the research that that's actually compounding each generation that's exposed to this diet, which is, I think, one of the reasons that we're just seeing such an rapid growth in the incidence of insulin resistance, which is quite worrying, and not just for PCOS, but for all the other downstream effects of that.
And what about other drivers, like, for instance, the big baddie of all conditions is inflammation or runaway inflammation, self-propagating inflammation rather than resolving inflammation. What's the issue here, and is it driven by hormones or are hormones driven by it?
Again, with PCOS specifically, I put it through the lens of for this individual patient, what is the thing that is interfering with her ovulation, her regular ovulation, and what is the thing that is skewing her to high androgens instead of progesterone, for example. And for about 70% of women who qualify for the PCOS diagnosis, the thing that's pushing them there is insulin resistance. Then there's about 30% of women for whom there's no evidence of insulin resistance. There seems to be something else going on. And amongst that group, there is a smaller group of women for whom I think the chronic inflammation is perhaps one of the biggest driving factors. I actually refer to that in my book and in my work as inflammatory PCOS. It's not to say that there's no inflammation involved in the other types, because of course there's kind of a metabolic inflammation that comes from insulin resistance itself. So that's part of the dysfunction. That's part of the picture. But I guess when I say inflammatory PCOS, I'm talking about the smaller subgroup of women who maybe have more of the kind of immune inflammation, related to food sensitivities and gut, microbiome problems, and that kind of chronic inflammation. And that does seem to be a trigger or a driver for some women. But I'll say it's not the majority. I don't see PCOS as an inflammatory condition the way I would say endometriosis in contrast. But yes, you're right. I think it certainly plays a role for some women. And so I'll just talk through the other two types of what I see as what I call the types of PCOS. So there's the insulin resistant type, which is by far the majority, and then the inflammatory type I work with, and then there's a post-pill PCOS as well, which we can talk about if you like. And then finally, the fourth one is quite a small group of women, but I call that adrenal PCOS. So these are women for whom there's actually quite a different situation going on. They've got their androgens or male hormones are primarily from their adrenal glands, and their ovaries do not seem to be affected as much. So that's a different picture, and women in that group need different strategies than the classic PCOS.
We often term this adrenal fatigue and things like that, which I think is probably a misnomer because it's the brain that changes in volume. But there's a crosstalk. It's the hormones that talk between these two organs and glands, if you like. Are we talking about a stress-induced adrenal secretion of these hormones, or is there some other mechanism there?
No, it's pretty much, it's stress-induced. Certainly stress can worsen it once it's established, once there's that pattern of excess male hormone from the adrenal glands. Then one of the strategies is to reduce stress, to manage that, as well as, using some of the natural medicines that help to regulate that brain-adrenal HPA axis communication. But what's interesting about the adrenal PCOS is the little bit of research I found that has correlated it with stress during puberty. So in particular, like whether a parent died or there's something like a big hit of stress around that kind of 13, 14-year-old age, which when I read that, I thought that really makes sense. That matches with some of what I'm seeing with my patients. And it just kind of makes sense to me as a biologist and as a clinician that when the reproductive hormonal system is calibrating itself and maturing and becoming established, it's learning essentially its environment, to have a big disruption like that at such an early age seems to have, I hate to say permanent, but kind of long-term effects. Yeah. And there can also, to be fair with the adrenal type of PCOS, there's clearly a role of environmental toxins as well, like hormone disrupting chemicals as well. There's going to be a genetic component to that, as there is with any condition really. So yeah, it's worth mentioning because even though it's only a small group of women, I'm sure there are some of your listeners who have patients who fit into that category and might now be able to think, yeah, okay, that gives me a different direction to take.
That's a really interesting point you make, and I'm just like my mind's going down rabbit hole here. I'm wondering about EBV. You know, you've got hormonal priming.
Yep.
You've got the perfect storm of stress, hormones, and infection as a priming sort of, let's say, an imprinting agent, and that's only a small section of PCOS.
That would just be
that's the other thing.
No, go ahead.
I think it's really interesting as well. During periods of growth and development, bursts of growth and development, like infancy and like puberty, the microbiota changes, the microbiome changes to sort of favour the proteobacteria, and then comes back into sort of swing for other bacteria later on. It's really interesting what's happening here, and I wonder, who knows? But I wonder if there's any sort of potential. Is there a potential place in which we can intervene here to rebalance things so that maybe they're not so permanent? I mean, that's a big question mark.
Intervene with the microbiome.
Yeah.
Potentially. Yeah, potentially. I mean, we know that changes with the microbiome can influence the HPA axis. And you're right about the influential windows. So, when we're a fetus or when we're an infant or when we're in puberty, those are all very influential times, like little windows where we're more vulnerable, for example, to endocrine disrupting chemicals. We're more vulnerable potentially to microbiome disrupting agents during those times. So unfortunately, some of us just, get unlucky if you get the wrong kind of stress during that vulnerable time.
So let's talk about these EDCs, because this is something they're ubiquitous in our environment. We're not talking about plastics now. Now we're talking about microplastics. Endocrine
disrupting chemicals is a broad group. So it includes, obviously, plastics, pesticides would probably be a pretty big one in that group. Heavy metals as well. Actually, lead and mercury are endocrine disruptors. And, they have the flame retardants in furniture and the fire retardants. And, there's lots of different factors. And that's almost the whole podcast on its own. And I'm not fully up to speed on all the different nuances of that, or even I'm not even sure how much we even know at this stage, because I find it's quite a burden for patients to have to think about that and try to avoid things. I mean, I give them some common sense advice, to avoid any unnecessary pesticides. But at the same time, I don't want them to become anxious about it, because I think, in reality, for most of us, I think especially for something like PCOS, I think some of the damage was done, when they were exposed as a teenager or exposed in utero or whenever it was. So, I mean, all we can do is, for their condition, is use the tools that we have, which are, diet and supplements and herbal medicine, and also as a society, I think, work to reduce the burden of toxins that are affecting the next generation.
This is obviously a smaller segment of the women that are affected with PCOS, Lara. What about some of the other types? Obviously, you're going to be delving into this at the ATMS Symposium later on in this year, but can we discuss maybe, the post-pill type of polycystic ovarian syndrome?
Yes, let's do that. So after the insulin-resistant type, which is the most common, I would say the post-pill type is the next most common. It's post-pill PCOS is not an official designation, unfortunately. I mean, that's what I call it. That's what a number of my fellow clinicians call it. It's a very real thing that we see in clinic. There's almost no research into it, which is kind of disturbing. But so it's a situation where someone was fine before they went on the pill, maybe were on the pill for 10 or 15 years, and come off and then get a surge in androgens, can't get their ovulations going, probably have some, post-pill acne, show up polycystic ovaries on ultrasound, and panic, basically. And, I think two things I'll share about that for the listeners is, number one, that can be a temporary state. I'm really confident to say that that is, sometimes it's a longer term state, but sometimes they just need 12 months or so to recover from the steroid drugs of the pill, essentially, and to start to ovulate and for their ovaries to get their groove back and stop making so much testosterone. The endocrinologist who helped me with my book Professor Geraldine Pryor, she described that kind of situation, maybe sort of a post-pill PCOS, as temporary, could she call it temporary adaptive and ovulatory androgen excess? So she's kind of saying, this is just a moment in time where for the reason of coming off the pill, the ovaries sort of move into this temporary state of not really doing what they're supposed to. And it's understandable given how strong those drugs are and what, the suppression the ovarian function has been under for the 10 or 15 years on the pill. It's not a surprise that it can take them a while to recover. And what makes me sad is that when women are given that diagnosis, they just, of course, accept it as that they have a disease, they have a long-term condition, they're going to need metformin, they're going to need IVF or whatever it is. It just kind of quickly snowballs out of control, because often they'll have come off the pill to fall pregnant, and then they feel like they're on this really short time frame. They don't really want to wait 12 months for their periods to come back and their androgens to come back to normal. So they start more interventions straight away, and that makes me quite sad, obviously.
And there's the stress driver.
Yes, and then the stress is making it worse. Yeah. So I guess my advice would be to come off the pill sooner rather than later.
Right, okay.
Yeah.
Let's talk a little bit about interventions. And obviously this is going to be a huge area, but from what you're saying about the insulin-resistant type being the most common, are we really saying, okay, how do we intervene? Diet and lifestyle? Is it just diet and lifestyle, diet and lifestyle, diet and lifestyle?
Diet is huge for that first type, that insulin-resistant type, which is the majority of women who qualify for the PCOS diagnosis. They need to quit sugar. That's how I see it. I'm in the camp that feels that the high-dose fructose is one of the biggest inducers of insulin resistance. So I'm quite clear with my messaging around this, because I see a lot of patients kind of struggling, quite confused about a low-carb diet and trying to cut potatoes and every other thing, and feeling hungry all the time, and yet still having paleo desserts and smoothies and fruit juice. So I just want to be clear that for insulin resistance, the most effective dietary intervention I find is to remove those dessert type foods. So sweetened yogurt, fruit juice, dates.
Do you have to quit sugar totally, or can you still have
a
teaspoon?
There's a sweet spot, actually. This is in my book. So there's fructose is interesting because there's up to about 25 grams of fructose, which is not grams of total carbohydrate. That's just specifically fructose.
Yeah.
Up to about 25 per day is actually quite healthy and improves insulin sensitivity. So that would equate to about 3 pieces of fruit in the day, for example. Anything above that, depending on your genetic situation and your sensitivity, can start to induce insulin resistance. And it's not easy. It's not that hard to have more than 25, as you can imagine. Like if you're having fruit juice and sugar in your coffee and date balls and smoothies and sweetened yogurts, you can be up in the 100, 150 grams of fructose per day, which is obviously quite different than the 25. So, when I speak about fructose, I always speak about specifically more about the quantity. Yeah. And my little rule of thumb is if it's dessert, then it's too much fructose. If it's essentially dessert, it's too much fructose. Yeah. But if it's whole fruit, that's different.
What about the message, though, about saying, okay, they're having their 3 pieces of fruit, so they're quote-unquote healthy, but they're also having 3 cups of coffee a day with 1 or, heaven forbid, 2, I used to, then they're driving things way up.
Yeah, the sugar in the coffee has to go. So, if my patient, if that's very stressful for them to think about not having that sweetener, then I might look at temporarily using stevia or xylitol or something like that to give them that sweet sensation and help them come off.
What about lifestyle interventions, Lara? Historically, this has been the big brick wall to success of therapy. How do you start it, particularly when they already might have a weight issue, and how do you keep them on the golden path?
So we're talking about exercise, which is very effective, very important. It improves insulin sensitivity. With my own patients, I almost never speak about weight loss anymore. I speak about insulin sensitivity. I speak about the metabolic benefits of exercise for their own sake, not as a way to lose weight, because I feel like perhaps what I've observed with some of my patients is when they get discouraged is when they're doing everything right and they're not seeing the scale change, for example.
Yeah.
That just seems to throw them right off. So I'll say, look, I don't know exactly what's going to happen with your weight. I'm confident that in the long term, your body's going to find a new set point. It's going to come to the weight that's healthy for it. But in the shorter term, we're just focused on health. And we're specifically focused on getting your insulin down, into a normal range, not down too low, but certainly with fasting insulin, I like to see it below 8, between about 4 and 8. That's for any clinicians listening out there. And that gives a metric that you can track with patients, which I think they find quite helpful. So you can say, okay, we're going to stop sugar, concentrated sugar, we're going to do some exercise, eat full solid meals, get sleep, and then we're going to recheck your insulin in a few months. And that's going to give you that positive feedback that you're doing things right.
What about different types of exercise? HIIT therapy, I guess with regards to dietary measures, and you've also got things like intermittent fasting, but with lifestyle interventions, with exercise, do you ever employ specific types of exercises or techniques?
I'd like to more because I've also seen that research about the value of strength training, and it's pretty convincing. So in terms of counseling my own patients, I do mention strength training. I don't have the knowledge to kind of direct them specifically. So, but even as we're talking, I'm thinking I think I need to give them a bit more direction with that, because strength training doesn't have to be complicated. I started doing just some of my own kind of squats and push-ups, and what's great about strength training is some of it you can just do at home.
What about keeping people on that? What about long-term success with therapy? Do you ever find that the best method of keeping people on track is to have these regular visits, that the gaps between visits lengthens, but that regular visitation, just to make sure that they're still cool with what's happening, checking in biochemically as well, I guess, make sure everything's on the right track with regards to their hormones and their insulin resistance and things. Do you ever find this sort of long-term guidance is the best way to go?
Yeah, well, the great thing about being a woman, I'll say, is that we have this handy barometer of our health, which is our periods. So with my patients, especially with PCOS, it's like if you can stay at the point where your period is coming regularly and your androgen symptoms are improving, then that's your feedback that you're doing the right thing. And when you start having sugar again and stop doing exercise, the periods are going to become irregular again. You're going to start to get some of the other symptoms of PCOS. So it's quite a handy feedback mechanism in that way. But every individual is going to be different. Certainly I've had patients who are just, I guess, not at the right point in their life to take that in, or maybe I'm just not the right person to be telling them. But not everybody can just quit sugar and run with it. No, it's obviously, they have to have their own individual personal reasons why they want to do that.
Yeah. Let's look at other therapies like herbs and nutrients. In the past, there's been these old favourites like gymnema and bitter melon and things like that. Do you find any? I am a full advocate of individualising therapy, so I'm not saying we should be prescriptive about this, but do you ever find there's sort of go-to herbs and nutrients that you usually employ?
So there's a few that I mentioned in my book, of course, and I'm going to just kind of state them now because so we're talking now for the classic type, the insulin-resistant type of PCOS. I'd say the number one is magnesium. It sensitizes the body to insulin. I find it works, well, observe that it works as well as metformin with my patients, and it obviously has other benefits too, so it's quite a nice treatment. Next down from that, a couple of the nutrients that you need for ovarian signaling are zinc and vitamin D. Those are both quite important, especially if they're deficient. The next nutrient that gets a lot of research is something called inositol, myo-inositol.
Yes, right.
Which helps with insulin signaling. It's done smashingly well in clinical trials for PCOS. It's kind of a superstar for PCOS right now. And the next one I'll mention, because there was recently some Australian research about it by naturopath Susan Lorenz, on the herbal combination peony and licorice. So that's available in tablet form by a couple of brands in Australia, and I use that quite a lot. It helps to reestablish normal ovarian signaling, and also has an anti-androgen effect.
Yeah. it's kind of this sort of hero TCM combination, wasn't it? It was almost like two herbs that were just the stars.
Yeah.
And it almost became a term that where two herbs joined for one name. It's painlily.
Exactly. Yeah, so I use that quite a lot. And I also say, I get good results, not just me, and other clinicians I talk to are getting good results with that kind of protocol.
As we've said before, you'll be speaking at the 2018 ATMS Symposium in Sydney. What can delegates expect to learn from you and indeed some of the other speakers? I know that you aren't up with all of their talks, but what's the general feel of things? What can we expect to learn from this symposium?
I think the main takeaway will be to look beyond just the label of PCOS. For example, my talk is called Deep Diagnosis, the different drivers of PCOS and how to treat them. So it's kind of similar to what I talked about just now, but in more detail, and I'll be providing more treatment ideas for each type. And it's all part of an evolving understanding of PCOS, that it's not just the polycystic ovaries on ultrasound. It's a whole body hormonal condition. It's more than one. It's not just the one thing. It has different causes for different women. So it's important to look at the individual patient sitting in front of you and run through some of those questions that I mentioned, including question number one, does she really have PCOS?
I've got to say, I really admire the way that you look further than a label. But I think one of the reasons that I most admire you for, Lara, is that you're not just dedicated to your patients, but you're dedicated to your profession and spreading the word about better care for these women who are undergoing these issues, especially PCOS, which we discussed today. Thanks so much for joining us on FX Medicine.
Oh, thanks for having me.
This is FX Medicine. I'm Andrew Whitfield Cook. If you're loving our FX Medicine podcasts, please don't forget to share us with your colleagues, family and friends.